Lisa. Thank you all for attending this first in the second series of the Chronicles of Wound Scene Investigation webinars. Please note, if you have any questions throughout this evening's presentation, please utilize the Q&A box, not the chat box, and we will address as many questions as possible at the end of the webinar. And as a reminder, this webinar is being recorded. So I am Kath Bogey. I'm a biomedical engineer based in Cleveland at the Cleveland VA and at Case Western Reserve University, and I'm the current chair of the Education Committee for the Wound Healing Society. And I will pass introductions over to our speakers. Foy.
Hello, hi. I'm Dr. White-Chi. I'm the medical director of the wound healing program at the Portland VA, and I'm also an associate professor at Oregon Health and Sciences University in Portland, Oregon.
And I'm Lisa Gould. I'm a plastic surgeon that's been taking care of difficult wounds for about 30 years now. And I was one of the original speakers for the wound scene investigation. So I'm really happy that we're turning this into the Chronicles and doing these webinars.
I'm Mohamed El-Masry, assistant professor at Department of Surgery, Plastic Surgery Division, Indiana University. And my research focus on regenerative wound healing, and I'm pleased and delighted to be moderating this session today. And without further ado, I would just start with our first speaker today, Dr. Lisa Gould. Up to you.
Trying to advance. There we go. So today we're going to talk about hyperbaric oxygen, topical oxygen, and how they impact wound healing. And this is coming out of one of the wound scene investigation presentations from 2014, in which we talked about radiation tissue damage and the effect of hyperbaric oxygen therapy. So because we wanted to have our focus on oxygen for today's session, I wanted to give you a little bit of an introduction to hyperbaric oxygen therapy for those who don't work with it clinically. So what is hyperbaric oxygen? It is the intermittent administration of 100% oxygen delivered under pressure. And on your left lower part of the screen, you can see what a monoplace chamber looks like. And that's very typical for most wound care centers. The entire chamber is filled with oxygen and the chamber is pressurized. And you can see that the patient or some lovely worker who got put in the chamber will lie there and breathe the oxygen under pressure for approximately 2 hours total. And then on the right, it shows the multiplace chambers, and they're not very common in the United States. They're very large, and the patients you can have multiple patients in there, and they wear hoods that deliver the 100% oxygen, and then the chamber is pressurized. But these are very good for intensive care unit patients, surgical patients, anyone who might need an attendant, and that's really where their greatest use is. You might ask, what does hyperbaric oxygen do? Well, it's because it's a gas and it's under pressure, we have to understand the gas laws. And that's, as one trains to be a hyperbaric clinician, that's one of the things that we have to dredge up is go back to a little bit of physics and learn some gas laws. Dalton's law is one. So if you are currently at sea level and breathing room air is 0.21, the partial pressure of oxygen in room air. And then at sea level, it's 760 millimeters of mercury. So the partial pressure of oxygen in a liquid in the room that you're in would be 159 millimeters of mercury. Henry's law talks about the amount of gas that you can dissolve in a liquid. So, for example, when you open up your soda bottle, you are experiencing part of Henry's law because that gas is not well dissolved. But we talk about it with oxygen dissolving in plasma. And so the amount of the gas that dissolves in a liquid is proportional to the pressure. And then Boyle's law shows that the volume varies inversely with the absolute pressure. So that's a direct proportion. In the right-hand lower screen, this is a picture I took when I was overseas in Sweden, and the styrofoam heads were put under great pressure, more like 3,000 meters of water. And you can see that it does compress the air that's in between the bits of styrofoam. But we never treat people that strongly. Next slide. So oxygen is transported by two mechanisms, and you can see the hemoglobin molecule on the left, and one is through chemical binding to the hemoglobin, and then the second mechanism is oxygen that's dissolved in the plasma. Each hemoglobin molecule combines with 4 oxygen molecules, so one on each of these subunits, and then each gram of hemoglobin carries 1.34 cc's of oxygen. So 15 grams of hemoglobin, which is kind of like the normal male level of hemoglobin, can transport 20 cc's of oxygen per 100 cc's of blood at 20 volumes %. When oxygen is transported by hemoglobin, it then has to unload it in the tissue. And increasing the partial pressure above 60 doesn't really increase the oxygen content in the blood, because the blood is already 97% saturated when you're at room air. But it is affected by pH and temperature. So exercising muscles will have a higher temperature and a lower pH, and therefore be able to extract more oxygen. Once the hemoglobin is fully saturated, any increase in the FiO2, or the inspired oxygen, really only affects the plasma dissolved oxygen fraction. And on the graph, you can see the effect of increasing the inspired oxygen at 1 atmosphere of pressure, which is where you probably are at right now. And you really can't increase it very much. But as you increase the pressure to 2 atmospheres or 3 atmospheres, you can increase the amount of oxygen that's dissolved in the plasma. And I like this graph because it really shows us the difference of pressure. So if you have inspired oxygen at 21%, which is room air, your partial pressure of oxygen is 159. And then as you get to the alveolar ventilation, because of oxygen consumption, as you go through the alveoli, it goes down to 100, and then goes down even further to the arterial PO2. And finally, by the time it gets to the cells in the, if you're breathing 100% oxygen, those numbers go up. We don't really know what the numbers are in the arterial or the cellular yet, or at least I couldn't find it. And so that's at 1 atmosphere of 100% oxygen. But then if you increase the pressure to 3 atmospheres, then your inspired PO2 is 2,233. With a little bit of oxygen consumption in the alveoli, it goes down to 2,183, but that's 21 times normal. So even with the VQ mismatch and a little bit of oxygen consumption, the cellular PO2, by the time it gets to the toes, is much greater than what it would be at room air breathing oxygen. And as most of you know, there are many oxygen-dependent processes in wound healing. Affects fibroblast function, collagen cross-linking, angiogenesis by increasing VEGF, affects macrophage and neutrophil function, how we kill bacteria. It's an oxygen-dependent process. Antibiotic transport is oxygen-dependent. And many of the enzyme reactions are oxygen dependent and as a cell signal. So remember that this was presented in 2014, and it was what we knew as of 2014. So if you have new knowledge about what oxygen does, we're going back in time, and wound scene investigation was in 2014. So now we're going to start and show what we talked about at that time as our wound scene investigation team, which was composed of both basic scientists and clinicians. The late effects of radiation, I like to call the gift that keeps on giving. Thankfully, we don't see very many patients that look like this anymore, but you can see the effects of a burn, a severe burn to the skin and the subcutaneous tissue, and then a wound in the center. And that's usually about 30 years after the original cancer was treated. These are examples of some real life patients. This is one that I took care of who was a 63-year-old who had had breast cancer that was treated with a modified radical mastectomy, and then she had adjuvant chemo and radiation. Tried to have an immediate reconstruction, which failed, and presented to the wound center 6 years later with intermittent drainage, pain, and fibrosis of the skin under the mastectomy scar. She had actually been going in and out of the emergency room with this drainage and with pain. And so rather than open up the whole thing, because we felt that she wouldn't heal well if we just did that, because you still had the radiated changes to the tissue, treated her with hyperbaric for 20 treatments, no other change in her treatment regimen, and the drainage resolved. She had decreased fibrosis, much more pliability of the skin, and decreased pain. And actually, we avoided an operation in her. This is a potential candidate for hyperbaric therapy, given the history of radiation. So this is a 65-year-old person with no previous leg ulcers who had a squamous cell carcinoma in situ, treated with only radiation and not surgery, and then developed recurrent cellulitis requiring systemic antibiotics. The leg ulcer developed in the cellulitic area and then has not healed. But the vascular studies of the leg, the venous and arterial, are normal. And we'll talk about that the radiation therapy actually doesn't affect the big blood vessels, which is what we look at with the vascular studies. And this is a severe chest wall wound in a 72-year-old female who received cobalt radiation for breast cancer like many, many years ago, but had a rapidly advancing wound, and the clavicle was exposed and dried, and she was referred for hyperbaric therapy, possibly not a candidate for surgery. And even then, some surgeons would want her to have hyperbaric first. 6 weeks after the referral, you can see the wound over the clavicle. And then apparently she was lost to follow-up, and then came back and said, well, I think this is because I changed my deodorant. And the clinician said, no, I don't really think so. And this is a pretty characteristic. You can see the changes in the skin where it's white and has some telangiectasia around the wound. And then the base is very fibrotic. And debriding that is an exercise in frustration, because you debride it and that yellow, very fibrous tissue just recurs and it doesn't grow granulation tissue. This is an example of what that can look like. Several months later, you can still see the exposed clavicle and the wound in the axilla. But those telangiectasia, and you can imagine how thick that skin feels. That's very, very characteristic of chronic radiation changes. So you can think about, if you're in a wound care setting, what treatments are offered. Not everybody has hyperbaric oxygen available, so you might have to offer some alternatives. Perhaps the clinicians offer pentoxifylline or nonsteroidals or stem cell mobilizers like CSF or vitamin E. And all of those may have some effect, and we'll look at why that would be. What is the clinical appearance over time? Well, at first, it's pretty subtle, and you can see the top right, a little redness, like the patient had been out in the sun, only it's in a discrete area. The skin then can become tender and sensitive with some blistering of the outer layer and some weeping, as you see in the next photo down. And that can actually, it can be so severe that patients have to stop for a while before they can resume their radiation therapy, or they may just be treated with topicals. And most medical oncologists or radiation oncologists have a regimen that they use, and they advise patients on that. We don't usually see them in the wound center for that, but sometimes it's severe enough that we do. The dryness and peeling may occur after 3 to 4 weeks, just like it would if you had a really, really bad sunburn. And then the skin starts to become darker and the hair follicles have been affected, so the hair is gone and it can become dry and itching. But the late effects is really what hyperbaric therapy will treat. And sometimes it's thinning of the skin, but the skin can also become hardened and scarred. And in that lower right photo, it's subtle, but if you press on that person's neck, you would feel how fibrotic it is. And anything like a surgery or a wound in that area will demonstrate poor wound healing. And it can be real, it can really fool you. Sometimes the changes are so subtle that surgeons will go ahead and operate in the area and then the patient doesn't heal. This is an example on the left, how subtle it can be, just a little tinge to the skin. In the middle photo and the right lower, those are both the same person, just different sides of the mandible and the neck. And it's red and a little bit fibrotic there, but on the lower right, bad enough that the hardware from the mandible fixation became exposed. And that's a big problem for that patient. The pathophysiology of the radiation injury starts with the acute injury, where there's direct toxicity to the cellular DNA that leads to mitotic death. That's usually self-limited. But we do see that the patients who had the most severe reactions during their treatment initially are often the ones that are coming with problems later. Subacute phase is 2 to 3 months after radiation and may only occur in a few organ systems. And then the delayed effect is considered to be 6 months after completion of radiation to many, many years, as I've shown in some of the photos. And as I mentioned, it's often precipitated by an additional tissue insult or trauma, such as one that a surgeon might incite. It's a really insidious process, and Feldmeyer has done the most work on this, and both Marks and Feldmeyer, you'll hear those names a lot in any discussion of radiation therapy. And Marks developed this triangle of hypoxia, hypovascularity, and hypocellularity, and how they all feed into each other, where there's impaired vascularity, the depletion of the cell lines, and it impacts all phases of wound healing, and it can be progressive over time. The Mark's 3 H's, as we just saw, were hypocellular, hypovascular, and hypoxia. But more recently, people have looked at the fibroatrophic effect and saying that really this process begins at the initial time of radiation, whereas Marks was looking at it as a late effect. But we now know that that cellular depletion is very important, particularly with the it seems odd if you have cellular depletion of fibroblasts, but it's a lot like a keloid, where you have an exuberant fibrosis despite a paucity of active fibroblast and loss of stem cells. Oh, and if you look at that photo, you see fibrotic changes around the wound, but you also see the fibrotic changes in the wound. It's that yellow non-granular tissue that simply won't heal and very hard to remove as well, because the whole area is fibrotic. So the therapeutic strategies, if we get back to that the question of what might you use in your clinic, one obviously is to control cutaneous infection, but anti-inflammatory drugs have been shown to have some effect. Cyclooxygenase 1 and 2 inhibitors, pentoxifylline may improve the blood flow through the little tiny blood vessels that are left, but it's really an endarteritis. And so it doesn't usually get to the wound itself. Vitamin E for its antioxidant effects might be too little too late. An anti-TGF beta agent in order to decrease the fibrosis. Etanercept as an inhibitor of TNF alpha to decrease some of the inflammatory response, or stem cell mobilizers are possibilities and were written about in 2013. At that time, remember, we've taken you back to 2014. Autologous adipocyte-derived stem cells were being looked at as a possible treatment for cutaneous radiation syndrome. And I think that there's a lot more research on that now, although it's still not mainstream therapy. So the accepted strategies for treating radiated wounds is high quality standard wound care, moist wound care, and debriding necrotic tissue. But as I said, the necrotic tissue tends to come back. So we need to use some other modalities. Negative pressure wound therapy may be beneficial. Nutritional repletion and hyperbaric oxygen therapy is one of the accepted indications for treating radiation or radiated wounds when it's a delayed effect. How does that work? The wounds are very ischemic, similar to other ischemic wounds. So at 1 atmosphere, which is where most of us are living, the gradient between the skin edge and the wound center is very small. But as you increase the pressure and therefore increase the oxygen tension to the well-vascularized tissue, then you drive that gradient to be higher, and that stimulates our stem cells to be released and activates some of the growth factors on the edge of the wound that then can migrate in. So it's been shown that hyperbaric oxygen therapy will stimulate angiogenesis and tissue, and therefore tissue oxygenation, and that's been studied since 1999. Reduction of fibrosis was studied by Feldmeyer, and then the mobilization and stimulation of stem cells was more recent. Mostly Steve Thom. I think Goldstein was the first author on this particular paper, but Steve Thom has really done the yeoman's work on mobilizing and stimulating stem cells. That takes a while for it to be an effect. They're coming from, we think they're coming from the bone marrow, although they may be coming from resident stem cells. So if you measure the transcutaneous oxygen while someone is getting hyperbaric, or an animal or a human are getting hyperbaric therapy daily, you see the TCPO2 go up. So the black line at the top, that's normal controls, and then the clear triangles are the patients that are receiving hyperbaric oxygen therapy after radiation, and it pretty much plateaus at day 20. But that's why when I talk to my patients, I tell them we really won't see a visible effect until at least day 20, and that's when you start to see some granulation tissue in the wound. And some of this may be because of the human stem cell mobilization. So again, this is Steve Thom's work where he measured angiogenesis and stem cell mobilization pre-hyperbaric. So he's measuring the CD34 counts in the cells that were extracted from the blood. And even after one treatment, that CD34 count is twice what it was pre-hyperbaric oxygen therapy. And then at 20 treatments, it's 8 times what it was. So pretty good effect of mobilizing stem cells. And these would be from the bone marrow because they were measured in the blood. So we see some good outcomes. Unfortunately, a lot of it is anecdotal. And even the diabetic foot ulcer literature is brought up and then refuted and doesn't have wide acceptance. So there's little data because it's hard to do the clinical trials. It's not like you have a company that would fund a clinical trial in hyperbaric. So there are efforts to create a registry, or there are registries that exist, but it's slow going, getting enough of the same types of patients in order to have good data. And that's what we're all about. So the Undersea Hyperbaric Medicine Society recognizes 14 indications for hyperbaric. I think there's 14. They've just added a couple more. And the ones that are highlighted in red are the ones that you might see in wound centers. So the others are going to be acute treatments or in a 24/7 unit, units that might be attached to the hospital or associated with emergency rooms. But enhanced healing and selected problem wounds, the only ones that are paid for specifically are diabetic foot ulcers in terms of Medicare reimbursement, delayed radiation injury, which can be soft tissue or bony necrosis, and then osteomyelitis, which needs to be chronic and refractory. All of the other indications either are not reimbursed or are covered in an acute unit, where, like, I used to take care of carbon monoxide poisoning all the time, and it works very, very well. So the reason we're talking about that now is because we're going to move to discussing topical oxygen therapy, which to date has only been used for diabetic foot ulcers. So I will turn the reins over to Dr. White-Chi.
Well, thank you. Right, so the wound scene investigation, of course, back in 2014 did not discuss topical oxygen, but we thought it was appropriate to add to this session because there's been more and more discussion about topical oxygen. And you'll probably continue to see more discussion about topical oxygen at your various associations. One of the things we really want to point out is that when people talk about hyperbaric therapy and they talk about topical oxygen, they're two different delivery systems, but they're still oxygen. You'll even have patients who might refer to their topical oxygen as in-home hyperbaric, but we have to politely correct them and say, this is a different delivery system. And essentially, when we're thinking about the science of that and what we do and what we don't know. Next slide, please. So what we don't know. Now, Dr. Gould does an excellent job of outlining what we know about how oxygen heals wounds and reacts with wounds. And so when we were going over the literature and really figuring out, well, does it do all those things that we have a better understanding with hyperbaric therapy in the study at the tissue level? Does it impact those free radicals? What role does it have on antibiotics and augmentation? Does it impact those oxygen-dependent killing leukocytes? We just don't know because those studies have not been done. Next slide. But what we do know. So I'm going to walk you through a few studies that have led us to this journey where we are now with topical oxygen. So this is Free's work back in 2005. This is a pig study that was done. So what they took were 40 pigs. 40 wounds. They had 4 pigs, and they did 10 dermal wounds per pig, did full thickness sections. And they placed a topical oxygen delivery device on the wounds. There was no dressing, good to know in terms of when we get to the human trials. They had a continuous flow of 3 to 6 liters per minute. And they also measured the oxygen of the wound and showed a rise in the O2. This is not equivalent to the TCOMs, though, used in hyperbaric. It was a measuring device specific to their study. Then they did 3mm punch biopsies. And so on the upper right here, what you see is there's formalin-fixed paraffin sections that they stained for vascular endothelial growth factor. That's green. That's part A there, 7 days post-wounding. And under B, they were staining for smooth muscle actin in the green, also day 16 post-wounding. So you see between the control and the oxygen treated, much higher amount of green seen in those slides. The wound site PO2 levels also were measured under resting conditions on day 22, and you'll see an increase in that as well. On the lower right, these were formalin-fixed paraffin sections that were stained against antibody, stained using antibody against keratin 14, that's in green, to stain for the epidermis. And notice on the oxygen-treated side how very well organized that keratin is compared to the left side control. Next slide. So that was a pig study. Now we're moving on to a human study by Gordilla. What this was, they screened over 1,800, I was really impressed, patients in an outpatient wound clinic, but then they did non-randomized enrollments, either to hyperbaric or to topical oxygen. And really the decision as to whether the patient got hyperbaric or topical oxygen was totally dependent on the clinician. There were no peripheral arterial disease rules in this study for the topical oxygen or any TPO2 measurements that I could find in the study. However, just as Dr. Gould went over the CMS criteria for hyperbaric, they would have to fall under those criteria to be enrolled in the hyperbaric. So anyway, they screened all these patients, and for the hyperbaric side, there's about 32 patients where only 30% were diabetic. And on the topical oxygen, which I'm going to emphasize here with the scatter plot, there were 24 patients where half of them, 52%, were diabetic, which is a little bit different than what I would say my patients are. I would say the vast majority of them had diabetes. So this is looking at VEGF ratio and wound volume ratio, T0, the start of the study, and T2, that is 14 weeks. And the way they delivered this oxygen is it was an oxygen gas cylinder that allowed a flow of oxygen of 7 to 8 liters per minute. And this had to inflate to 101 kilopascals of pressure. They got 90 minutes a day for 4 days in a row per week. And so when you're looking at the scatter plot, the data to the left of the vertical line at 0.1, at 1, if you're to the left of that, then at T2, at that 14-week mark, then that indicates a smaller wound. And then if you're above the horizontal line, then you have more VEGF also at T2. The numbers at each of the data points indicate the age of the patient. So also a younger population than I'm used to seeing. Most of my patients over the age of 65, frankly. When they looked at this, remember, there are other items that they looked at, like TGF beta 1 and COL1A1, but they didn't see any change in that with the topical oxygen. But this is just kind of this is getting a little bit to that pathogenesis or how it might be improving at the cellular level, the wound healing. Next slide. So I was talking about with the pig study and then also with that last study, there were different ways that the oxygen can be delivered. And there are 3 main different ways. So the first one is the continuous delivery. And that was one of the first that came about, where this is actually a wearable device that the patient wears 24/7 over their dressing. It is not pressurized, and there has been some enhanced healing shown in some formal randomized controlled trials. Usually it's a low flow continuous oxygen and anywhere from 3 to 15 milliliters per hour, depending on the device. The device dressing is changed weekly, and there's no compression or humidification, which we'll see in some of the other devices. The one next to that is a low constant pressure. That's at 22 millimeters of mercury. So this would be something where they would do a session. The patient would do a certain timing of session, maybe 90 minutes for a certain number of days a week. Most of the studies that support this for wound healing have been retrospective database studies. There's minimal compression and no humidification. Then to the right is cyclical pressure. And I do note that that's saying 10 to 50 millibars versus the 22 millimeters of mercury on the low constant. I'm going to get to more detail on that in a second. But so when you think about the cyclical pressure, again, this is something where the patient would have a session, 90 minutes, 5 days a week. The cyclical pressure goes anywhere from 10 to 50 millibars, and that translates to a cyclical pressure distinct from the oxygen pressure, going from 8 millimeters of mercury to 38 millimeters of mercury. So it's still staying kind of, lower and higher than that low constant pressure. And you're creating the sequential non-contact compression, theoretically reducing peripheral edema and also helping lower the diffusion of the oxygen gradient. This also allows for pure oxygen at 760 millimeters of mercury, so sea level, but that can be pressurized up to 800 millimeters of mercury, theoretically optimizing enzymatic activity. Again, hasn't been studied, but that's the theory. Humidity can be added, and there has recently been a very robust randomized control trial that showed improved healing at both 12 weeks and 12 months. So let's talk about that study. So this is Frickbird's work that just came out in 2020. They looked at patients specifically with diabetes and chronic diabetic foot ulcers. They had to be either type 1 or type 2 diabetes, and they had to have a University of Texas classification grade 1 or 2. So 2, to remind you, goes into the tendon or capsule. Had to measure greater than 1 centimeters of mercury or less than 20 after debridement. All ulcers had to have been present at least 4 weeks and less than a year, and be receiving that standard of care. So everybody's still getting offloading, excellent diabetes control if possible, et cetera. This study did allow for modest limb ischemia. Anyone who had an ABI of 0.7 could still be enrolled. And to account for those falsely elevated ABIs, they did a secondary confirmatory measurement of distal perfusion adjacent to or distal to the index ulcer. They allowed patients who had toe pressures 30 or higher. But even when you go back and actually look at the data, on both arms, the sham and the topical oxygen, the mean pressures were 80. So although it sounded like they intended to enroll people with worse arterial flow, it sounds like they had pretty darn good arterial flow. So what they did is the primary outcome was the percentage of ulcers in each group that achieved 100% healing at 12 weeks. And they had this group sequential design that puts together this Kaplan-Meier curve. And you'll find that they had an odds ratio of 4.57 with the healing. And even when they accounted for the adjustment for the University of Texas classification, that odds ratio increased to 6. What I found really interesting also about this study, other than, they had a 4.5 times likelihood of healing the wound in 12 weeks over the sham arm, but even at 12 months past enrollment, they went and followed up that over 50% of those topical oxygen arm was closed compared to 27%. And everyone knows that the holy grail is not just closing, it's staying closed. So this, we need more studies to repeat this process and really look to also to see at the tissue level what's going on so it can be refined further. But this has been a pretty great study to change the dialogue about topical oxygen. Next slide. So, and then Dr. Carter and their group back just this year did a recent systematic review and meta-analysis. So what they did is they looked at, they were looking at eligible studies from 2010 onwards. They really wanted something that was recent. And they included 4 randomized control trials that you see here on this table. They analyzed the studies for patient and wound characteristics, outcomes, risk of bias, and quality of evidence. And then when they looked at the risk of bias judgment, it did result in 1 low-risk trial and 3 trials with some risk. The most problematic trial was Dr. Driver's trial, mostly only because because that was a continuous delivery trial. That's the one where the patient has to wear it 24/7. And it had an alarming red light the patient would have to see to know that it's not working or there's a leak, but it didn't have an alarm. So there might have been times where the patient thought that the device is working just fine and it wasn't. The Niederauer study was also continuous diffusion, but it had alarms to notify the patient of any problems. Frickbird study, we just went over. And then Serena's study was also continuous delivery at 15 mils per hour. So all of these showed significant healing. And in the end, their conclusion that it was a viable treatment for Wagner grade 1 and 2 diabetic foot ulcers. Next slide. So let's talk about some cases. That's even more fun. Here we have a gentleman who's had a heel pressure ulcer. He did have peripheral arterial disease, multiple revascularizations that to the point with vascular surgery said we've done everything we can and have been non-healing for 7 years. I first met this patient in 2014. Fast forward to 2020 when we have an option of possibly using topical oxygen. Next slide. So in 2021, we did get it pretty close, close to closure. So 2020 and then 2021, the pre-oxygen, you'll see a really small wound. Notice also though, and this photo almost doesn't do it justice, all the atrophic changes. I find it very interesting sometimes when, especially on these heel wounds, where you'll get, and it's not radiation injury, but you're still getting a lot of that fibrosis and atrophy that makes it so difficult to close those wounds. And then we just thought this is as good as it's going to get. We're like, heck, let's go for it. And did the, and he also has diabetes, and went ahead and did the topical oxygen and was closed shortly there and has stayed closed. So that's been really great treatment for him. Next slide. This is another patient who we did an early treatment. The diabetic foot ulcer had been present for a month, was doing offloading, getting good diabetes control, wasn't really getting anywhere. And then you can see, even just within a few weeks, the game changer in this particular patient with topical oxygen, how it really facilitated closing. Next slide. This was a recalcitrant heel. So this was a gentleman that I met who was staying at a skilled nursing facility. And at the time when we were ordering topical oxygen, we weren't always able to get it into skilled nursing, partly because of COVID, frankly, because there's a lot of training that would need to be done with the nurses. So in November 2021, saw him February 2022. He was the last patient in my clinic. And then I finished up in clinic, went out to the lobby and saw him in his wheelchair and using his heels to self-propel. So it's always a good reminder to get back to basics. I was like, okay, we need to get you an electric wheelchair because you can't use your arms. He was having shoulder issues. And so, and he also was completely immobile for other neurologic reasons in terms of his lower extremities. So we got the electric wheelchair around December, but February 2022, still having issues. Next slide. Next slide. March 2022, we'd had 40% wound reduction, didn't have any, I promise you it was closed a month later. He also had a really robust response to the topical oxygen, but there's more to this story. Next slide. In May 2022, it recurred. You can see how very small it is, but then the reason it recurred is, and the reason I want to stress this, is getting back to basics, not always relying just on our adjuvant therapy. Found out that the footboard, something had changed in his bed to where he was kept hitting his heel on the footboard. So you have that very fragile skin, and it doesn't take much to open it back up. And we were able to talk to the skilled nursing facility about making bed adjustments. Got him back on the topical oxygen, fixed the footboard, and he was closed, and he has now stayed closed. I haven't seen him for quite some time. Next slide. So pearls to take away. Dr. Gould, you can join me on these. Actually, I think Dr. El-Masry. Yeah, I was about to say, that's my hush.
Yeah, I would like to thank you, Foy and Lisa, for this very informative and detailed discussion about the very important topics, the hyperbaric oxygen and the topical oxygen therapy. And I think you laid down a lot of studies regarding the topical oxygen therapy, and Lisa already mentioned a lot of challenges with the hyperbaric oxygen therapy. So I feel that we can start our discussion now, and the gentle reminder for the audience or the attendees to put if they have any questions to add it to the Q&A, and we'll be trying to address all of them as much as we can. And if there is any question which we'll not be able to address it now, it will be addressed and then sent to the audience with the recording after we finish the webinar. So I think from the discussion today or the presentations today, we can appreciate that the oxygen is one of, or you can consider the oxygen is in our toolbox for the wound healing. And always think about like the oxygen therapy indications. What are the good candidate and what the other adjunct tools and modalities that we can use with the oxygen therapy. Additionally, how we can recognize and identify the post-irradiated wounds early, as Lisa already mentioned in details with pictures, early stages, progressing to the later stages, how we can catch those early so we can intervene and prevent the rapid progress to irreversible stages. Oxygen therapy is an important as an adjunct in ischemic wounds, as Lisa already mentioned, and how was like the oxygen therapy is important and how the mechanism of the oxygen therapy during the ischemic wounds. Also, we need to differentiate, and this would be one of my questions to the speakers actually. Usually, I know that Foy already mentioned what is the difference, and sometimes the patients are like, you know, confused and asking you, can I take it home? Can you make like, I would ask like Foy first, can you make like bullet, like, you know, difference between both therapies?
Well, I think, and I'd love for Dr. Gould to contribute to this as well. So, I mean, main difference for topical oxygen is it's local, right over the wound. It can be done at home. The session, I guess you could argue that the time and the days per week is probably pretty similar. And that also, we are not entirely sure how it works at the cellular level. And so then hyperbaric, if you want to put some bullets there.
Yeah.
Sure. So I think that, well, let me let me think again. No. So hyperbaric oxygen therapy is more difficult to administer to patients than we think, right? So when I screen somebody for hyperbaric oxygen therapy, they have to have a good heart. They can't have COPD so bad that they might do poorly under pressure. They have to be alert enough that we can wake them up for their air breaks in between and follow directions. They're going to be in a closed chamber that we can't get to them. And claustrophobia can be a problem. So there are a lot of reasons that patients don't qualify for hyperbaric oxygen therapy. The other thing is that they're really supposed to be, for reimbursement, supposed to have been maximally revascularized. So what does that mean? Some of our patients simply can't be revascularized. With diabetes, it's the problems are below the knee, and sometimes the problem is in the foot, and they just really don't have any blood vessels to allow revascularization. If that's true, does that mean that they're maximally revascularized? We don't know. So I think that there's a lot of patients who may benefit from something that gets them oxygen that's not hyperbaric. And to me, that's going to be one of the uses of topical oxygen therapy. What we need to have better studied is what's actually going on in the wound and who is best to qualify for one or the other. I think that Dr. White-Chi and I have talked about this for years. Don't be closed-minded just because you think it doesn't work. Look at the data. We now have some data which are different than what we've had before. So it's definitely worth looking at, worth studying, and figuring out who would be the best patients for it. And as the slide says, more RCTs and center studies are needed.
Yeah, that would be leading us to the next point of more randomized controlled studies and multi-center studies are needed actually, and more mechanistic studies to establish the evidence-based guidelines, as you mentioned, Lisa. And actually we have like some questions in the
Oh, great.
Q&A. And I think the first question is very important. So what is the effect does the hyperbaric oxygen have upon healthcare workers who work in multi-patient hyperbaric oxygen chambers? Is there like any occupational benefit and hazards observed?
Well, I don't think it's like the Michael Jackson where they get a benefit, but
Oh,
no,
goodness.
they have very, very strong. I've never done a multi-place chamber, so it's only what I've read about. But yeah, there's only a certain amount of time that they can be in the chamber as an attendant, and they have to keep track of their oxygen exposure. Just like if you're a diver, you keep track of your depth and your time there. And there are certainly workers who have become bent and workers who've had difficulty with oxygen toxicity. So they usually have an entry chamber, and then they go in to help the patient, and then they go out. So they're not in there the entire time. But they're in Europe, they've had surgery suites inside of hyperbaric chambers. And it's a really interesting concept, I think.
I think we have a second question. Why aren't the patients in these multi-patient, multi-place chambers simply breathing the oxygen without the hoods?
Oh, so that gets back to the workers
yeah.
And the attendants. So the patients are getting the 100% oxygen for a period of time, and they're pressurized. The attendants are in the multi-place chamber, but the chamber is 21% oxygen. But because it's pressurized, it's still a higher level. But they can spend longer there because of that.
Yep. So we have another question. Can you shed some light on the safety of the patient with VP shunts in hyperbaric oxygen chamber?
No. So if somebody has a VP shunt, or so you're talking about a ventricular shunt?
Yeah, I think yes.
Yeah. So if you think about why we have to know these gas laws, right? So liquids are not as compressible as gases. So if somebody has, say, a tracheostomy and they have a cough, we take out the air and we fill it with water, because then it won't decompress or expand. The bigger problem is as they come up from the dive, you get expansion of the gas, and then it can cause necrosis of the tissue. So if the VP shunt is all liquid and it's not a gas, it should be okay. But I have not treated a patient with a VP shunt, so I haven't delved into the pros and cons of that, but it should be okay.
Okay. So I have like a question, like a general question. So I think when you are like, screening your patients, like what is the first option in front of you, either the topical or the hyperbaric? Like for both of you, this question is like for both of you.
Yeah.
Well, I'll go ahead and talk about that. I have a barrier bias. So Dr. Gould is going to have different barriers, right? And they're kind of the flip of what I have. So I'm at a Veteran Affairs Medical Center. We do not have a hyperbaric center. I then have to, there are patients that, just really with the radiation injuries, those are the ones I'm like, oh, definitely. But there's a process where I have to ask permission, get it paid for by the community. And then I actually end up losing the patient because usually the hyperbaric is affiliated with a wound center. So, but I want the patient to get the best care. I'm going to get over my ego. But when it comes to our diabetic foot ulcers, and also with a lot of our patients having some of those issues that Dr. Gould mentions, heart issues, COPD, PTSD, claustrophobia, I don't even consider hyperbaric for them. But I also have access to the topical oxygen, which currently the one we use, which is from the Fritberg trial, is only available in the VA right now. So then Dr. Gould can talk about how her barriers are a little bit different.
Yeah, so that's my barriers. I don't have access to topical oxygen that has been reasonably validated, right? The blow-by oxygen, again, most of us kind of poo-pooed it, said that there's no way that that can work, but it's always worth taking a look at how you could make it work. And I think that's what's been done with these boots. And then I think those will be adapted to other wounds if they haven't already, in order to allow wounds other than diabetic foot ulcers to be treated. So when I'm screening a patient, I'm looking, it's all about safety. Oxygen, hyperbaric oxygen is actually a very safe treatment. We're not diving deep, and it's oxygen itself isn't flammable, but we're looking at other things that are flammable, and whether, because once you have the oxygen as the fuel, you could really incite a fire. So we go through that with the patients. Claustrophobia can be a big problem. Transportation can be a big problem because it is a daily treatment. It's a big commitment. It's 2 hours every day, Monday through Friday, for usually 40 treatments, sometimes 60. That's a really long time out of somebody's life. So it's a big deal, and it's very expensive if insurance doesn't cover it, or some patients may have a copay, which is just prohibitive. So that's another barrier to treating. So we always do the pre-authorization first to make sure that they'd be covered.
Thank you. Thank you.
And then another thing is that they have to be able to lie still. So we have some patients right now that could be candidates, but one of them has a back, it's a radiated wound, but it's a back wound, and he wouldn't be able to be comfortable in the chamber. So that's out. Another patient had radiation, had a tongue cancer and got radiated, and his trismus was so bad that he couldn't open his mouth, and I wasn't willing to put him in the chamber, because if something were to happen, he had bleeding or had a seizure, we wouldn't be able to get in there. So
thank you so much for like shedding the light for the difference and the barriers for both the treatments. And actually we are like heading to the end of our discussion session. So I think there is like still like one we can answer this question at like in 1 minute or something. So Lisa, you mentioned in the the mechanistic action of when you are increasing the pressure. So the question here is saying when you are increasing the pressure, the capillary pressure against the capillary pressure is actually increasing. Would it be better to be doing intermittent than continuous pressure?
Right. So this is a question that's always bothered me about hyperbaric too, and it's not been studied. If you look at the induction of angiogenesis with VEGF, I would think that if you treat for a few days, induce VEGF, and allow the blood vessels to start to grow and mature, that would be better than constantly hitting them with VEGF and getting immature blood vessels. But nobody's ever looked at that. But I think that's an interesting question, is which is better? Should there be a gap? But it would be a huge matrix to study. But I think that's an interesting idea. The other thing we see is when we do TCOMs on people, so if you measure their TCOM at room air around the wound, say it's low, and then you give people 100% oxygen with a face mask, it goes up. Those are the patients who qualify for hyperbaric therapy, but maybe they would get better if they just got 100% inspired oxygen too. As we saw in that little flow chart, it's going to go up. It may not be as much as hyperbaric, but it may be enough to help the wound to heal, because it's a threshold.
Yeah, thank you so much, and thank you, Foy, for this wonderful presentations and discussion, and to you, Kath, for ending the session, and if there is a question or poll.
Okay, well, thank you, Mohamed, for the moderation, and to Lisa and Foy for your great presentations. And thank you to our audience for attending the Chronicles of Wound Healing Investigation series, brought to you by the Wounding Society Education Committee and Wound Healing U. As a reminder, the recording will be available in your member-only account on the Wound Healing U in the next few weeks. And before you go, we have We do ask that you also complete some brief questions to help us to continue to provide content that is of interest to Wound Healing Society members. I believe these are showing up in the post-webinar poll. If you have any comments, you can please leave additional comments in the chat. And before we leave you, just to remind you that the next webinar will be on pyoderma, and it will be held on Tuesday, October the 11th at the same time, 6 p.m. Eastern. We look forward to seeing you all then. Thank you.